All right, everyone, we're going to get started with our next session. It is my honor to introduce Dr. Leslie Schover. She's a clinical psychologist specializing in cancer-related problems with sexuality or fertility. She received her PhD from UCLA and completed her postdoctoral fellowship in sex therapy and sex research at SUNY at Stony Brook. She was the faculty at University of Texas MD Anderson Cancer Center in behavioral science for 21 years and retired in 2016 to start a digital health company, Will to Love, which is no longer around. And she received the Holland Distinguished Leadership Award from the American Psychological Oncology Society in 2016 and in 2021, the Excellence in Clinical Health Psychology Award from the Society for Health Psychology. And in 2019, Will to Love won an Innovations Prize in the International Astellas C3 competition to improve cancer care. So Dr. Schover is going to talk about sexual health today, and we actually have some goodies to give away, which is exciting. So we have tickets that we passed out, and we'd like you all to fill out your information, and then we're going to have some folks come around and collect those, and then we are going to draw after Dr. Schover's presentation. So please join me in welcoming Dr. Schover.
Well, thanks for that kind introduction, and I can't take responsibility for the goodies, but I did suggest where we might get them donated from. So today I want to talk to you about the kinds of sexual problems that women experience after low-grade serous ovarian cancer, and some self-help strategies and medical treatment strategies that may be helpful, and suggestions for how to basically keep your sex life alive. So how often do women have sexual problems after ovarian cancer? And I know all of you are probably sick of just being grouped with general ovarian cancer, but when it comes to research on sexual problems, even ovarian cancer hasn't been studied as much as it should be, let alone its subtypes. So all we can really say is that after ovarian cancer, anywhere between 40 and 80% of women will experience new sexual problems, which is a lot. Many of those problems are related to younger women going into sudden menopause because of their cancer treatment, or to worsening the effects of menopause in women over age 50 because of their cancer treatment. And often these issues are not discussed by the oncology team. I'd like to think that MD Anderson does a little bit better job than smaller cancer centers, but anywhere this can be a very private issue that the team doesn't bring up. So what are some special issues for all of you? Well, diagnosis of low-grade serous ovarian cancer is at a younger age when sexuality and fertility are maybe even more central to women's lives, not saying that they can't be central, especially sexuality, to older women. The symptoms when you're first diagnosed may include vaginal spotting or pain with penetration, so when you have those symptoms later on, that can be scary and make you wonder if something's wrong. For 90% or more of you, surgery involves removing both ovaries, the uterus, and other pelvic organs, and fertility-sparing surgery, where only one ovary is removed and the uterus is left in place, is only really considered for selected women with very early stage cancer. And treatments that damage sexual function also include all the systemic therapies. So, do you need to have sex to be happy? Oh, well, no. But it does have some potential benefits. Sexual relationships are one way that women experience intimacy. Having sex helps women feel attractive and lovable and provides pleasure in their lives. If you are in menopause, having sex may, and I say may because we don't have the scientific proof we'd like to have, but it may help keep the genital tissue in the vulva and vagina healthy by increasing blood flow when a woman's sexually aroused, and also by stretching out the vagina periodically. Sexual problems after cancer are associated with more fatigue and distress and poor quality of life. But what's the chicken and what's the egg? It's very difficult to know. But we do know that at least half of women treated for cancer say that nobody ever mentions sex to them from their oncology team. And I believe strongly that every patient should be informed of possible sexual side effects of cancer treatment. Sorry about the breast in there, that's a typo. And at follow-up visits, a question should always be asked, like, how's your sex life going? Women should be provided with good self-help tools like brochures or websites or books and suggestions on what they can do. And they should be able to be referred to appropriate specialty care, which might include a gynecologist who has a special interest in sexuality, a physical therapist certified in pelvic rehab, or a mental health professional trained in sex therapy. Women are often not familiar with our own private parts, and I won't belabor this, but if you've not recently looked at your vulva in a mirror, I would encourage you to take a diagram like this. And I understand, by the way, that the notes from my slides are going to be emailed to all of you, so you don't hopefully have to frantically take notes or worry about that. But just to look at yourself in a hand mirror or a makeup mirror and identify these parts. Where's your clitoris, the opening to your urethra where urine comes out, the outer and inner lips of your labia, the vaginal opening, and the anal opening. And every woman should know that when she becomes sexually excited, there are physical changes that happen. Blood flows into the thick muscular walls of the vagina and into the vulva and into the clitoris, which have a lot of spongy tissue inside. The lining of the vagina sweats out little droplets of clear, slippery fluid, and that's what makes intercourse comfortable. And the top of the vagina opens up almost like a balloon inflating. And unfortunately, all of those changes happen more slowly and not as much after a woman goes through menopause. So what types of sexual problems do women have? Well, the biggest ones are pain with sex, which is often related to dryness, to narrowing and shrinking of the vagina and the tissues of the vulva, and that also may leave a woman with a lot of soreness after she has any kind of sexual contact. Loss of desire for sex is a big one, and we'll talk about that as well. And when you're not in the mood for sex or sex hurts, it's hard to get turned on and feel pleasure during sex. And then it's doubly difficult for many women to reach an orgasm, not because the cancer treatment affects the orgasm physical process directly, but because of those indirect consequences. So if we look at the different treatments that are most common, the initial big debulking surgery in the pelvis causes the sudden loss for a younger woman of her ovarian function with the vaginal dryness, pain with sex, often severe hot flashes that may interrupt sleep. Sex with penetration may be painful because of pelvic scar tissue, or the bladder may kind of descend into the lower area of the pelvis right on top of the vagina, and that can cause pain with deep thrusting during sex. A lot of women take aromatase inhibitors, and they are just death on your sex life. I'm sorry, they're great for cancer treatment, but at least a quarter of women who are on aromatase inhibitors have such severe pain and dryness that they stop having sex completely. And not to mention the joint and bone pain, which make it uncomfortable and make you have chronic pain and fatigue, which doesn't exactly lead to being in the mood for sex. A few women who still have their ovaries may have at some point those ovaries shut down with the shots, the GnRH agonists or antagonists, often combined with an aromatase inhibitor. Now, tamoxifen has kind of gotten a bad rap when it comes to sex, Actually, tamoxifen, although it acts in breast or ovarian tissues as an anti-estrogen, actually helps a little bit with vaginal lubrication. And although it can cause some hot flashes, a lot of women who are premenopausal don't go into a full menopause on tamoxifen, but may just have some irregularity in their menstrual cycles. We know very little about the impact of targeted therapies on sexual function. The immune checkpoint inhibitors do seem to be able to affect hormone production, but it hasn't been well studied. But they do have side effects of fatigue, nausea, and diarrhea, which again, indirectly, can interfere with sex. So just related to menopause, when women go through menopause and have very little circulating estrogen, which is even more so if you're taking anti-estrogenic drugs, there is a loss of vaginal lubrication with sexual excitement. Some is produced, but it's slower and less is produced. There can be a loss of the stretchiness of the vaginal walls, which makes the vagina feel tight and dry. When a woman does have sexual activity after menopause, she may be at higher risk to get bacterial vaginal infections or bacterial urinary tract infections because of inflammation and the friction from the sexual activity and the bacteria washing up into the bladder, And also, pain with penetration can lead women to tense the muscles of their pelvic floor without realizing it, and that makes the pain worse, and we'll talk about that. Any woman who has experienced pain with sex on multiple occasions knows that it can really mess up your desire for sex, because who looks forward to getting turned on and starting to have sex only to find it's painful? And also, the insomnia and fatigue reduce women's desire. So what can you do to try to keep your vagina and vulva as healthy as possible? Well, anything that promotes blood flow into those areas may be helpful because the spongy tissue and small blood vessels that make up those tissues get oxygen from blood, and that helps keep them a little healthier. But we don't really know whether it's important to stretch out the vagina, but we think it may help to prevent scarring and shrinkage. It's unclear how often a woman should stretch out her vagina, but maybe a practical idea might be to aim for 2 or 3 times a week. Now, before any of you think this, the average woman who doesn't have cancer in the US probably has sex about once a week. So aiming to have intercourse 2 or 3 times a week is really kind of burdensome for a lot of women, especially if you're going through a chronic illness. But there are other ways to try to get blood flow into the genital area. Getting sexually excited by just caressing from a partner, from self-touch, using any of the varieties of vibrators or sex toys, and luckily we're in an era where you can just go on the internet and find hundreds of variations of vibrators and lubes and other kinds of sexual stimulation toys, and also having sexual fantasies, which I think can be very helpful when you're having trouble having spontaneous desire. So there are websites where you can listen to erotic stories if you don't like very explicit videos or pictures, or you can read books of sexual fantasies or bodice ripper romance novels with explicit sex scenes. And so all of these things are a lot more easily available nowadays than they used to be. I do advocate that women who are having vaginal dryness try a vaginal moisturizer. And I'll explain, this is a little different than lubrication that you use when you're going to have sex. The moisturizers are meant to be used at least 3 times a week, like you might use a moisturizer on your face. And they are either suppositories, little tablets that melt inside the vagina, or gels that you put inside the vagina with an applicator that looks like a little tampon. Many women use them at night to minimize leakage, although it is good if you use one to take your finger and spread out some of the moisture onto the vaginal entrance and the inner lips of the vulva to make sure those tissues are getting some lubrication too. I look for products that have hyaluronic acid, which you may have seen advertised in all kinds of cosmetic products, and it is similar to a chemical that our own cells make that is a moisturizing chemical. Unfortunately, these vaginal moisturizers are pretty expensive, but often if you look at their websites, they will give a discount if you subscribe to them. So even though insurance won't cover them, that makes it a little bit more affordable. And some of the brands I think are good because they don't have a lot of extra chemicals and they do have hyaluronic acid, include Good Clean Love, which makes one called BioNourish, Femme Pharma, which makes Mia Vita personal lubricant and moisturizer, Hyalogyne, and Bonafide Reverie Plus. Although I think of all of them, the Mia Vita has the least leakage problem because some women find they have to use a mini pad after putting in the gel. Also, add a lubricant if you're going to have any kind of sexual activity, whether that's touching yourself, caressing from a partner, or having intercourse penetration. And I suggest using water or silicone-based lubricants. A lot of oncologists swear by coconut oil. Coconut oil may promote vaginal bacterial infections, and there's a lot of different kinds of coconut oil, and the only thing I can say about it is cheaper than a lot of these other lubricants, but I think that it's less safe and effective. It's good to look for a lube that doesn't have any perfumes or flavors like vanilla or strawberry, and I avoid the ones that you blow on them and they warm your skin because that's just extra chemicals. It is nice if you can avoid glycerin or parabens as ingredients, but the small amounts allowed by the FDA probably don't do anything very harmful. If it's a water-based lubricant, see if you can find out about something called osmolality. Water-based lubes have a tendency, first you put them on and they're nice and slippery, but they draw water out of the cells that line the vagina, so they leave you drier after using it than before. And a lot of the lubricants that are very popular, one of them unfortunately is Astroglide, have very high osmolality, and I don't recommend them. So the ones I'm listing here, Silk, Good Clean Love, BioNude, Yes, water-based, Mia Vita gel, are all ones that have the recommended low osmolality. And when you use a lube, you should lubricate all surfaces, your own vulva and vaginal entrance, your partner's penis or fingers or a sex toy, and keep that lubricant handy next to you in case you need to put on more, because even the best lubricant will dry out after a while. Silicone-based lubricants don't have the osmolality problem and they stay slippery longer. They're a little bit more expensive and they may stain clothing or sheets, and you have to be careful about whether they're compatible with silicone sex toys. Sneaking into the bathroom before you have sex is not a good way to use your lube. It's important to talk to your partner and say, you know, I have a medical problem now. So this lube is our friend, and we need to incorporate it into our foreplay. We can put it on each other and make that more fun and erotic. Hormone therapy for vaginal dryness can be effective, but we worry, of course, because 90% of women with LGSOC have estrogen-positive tumors. Now, research with breast cancer has suggested that using a very low-dose vaginal estrogen does not promote cancer recurrence, but we don't have those specific studies for you guys. And if the moisturizer and lubricant combination works, that's the most conservative thing. But if it doesn't eliminate pain, then talk to your oncologist and gynecologist, and you may get two conflicting answers on whether it's okay to use a vaginal estrogen. They come in tablets or rings. There is also an oral medication, osphena or ospemifene, which is very similar to tamoxifen. It's a selective estrogen receptor modifier, so it should not theoretically promote estrogen-sensitive changes in cancer cells, but it does help with lubrication, and you have to take it daily. Again, there's not enough safety studies in cancer patients, but theoretically, it may be a safe alternative. There's also a gel that has a hormone related to testosterone in it called DHEA. It's like a weak testosterone. It's called Intrarosa, and you can use it instead of vaginal estrogen, but you should know that what it ultimately does is it increases the estrogen locally in your vagina, so it has the same pathway. And both vaginal estrogen and DHEA have been used in women on aromatase inhibitors, but those studies have been done in women with breast cancer. Now, you may have heard about vaginal laser treatments or heat treatments, and they were introduced a few years ago with a lot of fanfare. And unless things have changed, insurance doesn't cover them, and women were paying as much as $3,000 or $4,000 for a series of office laser or heat treatments. And then, as I'll tell you, I am very skeptical that they really do much. The hope was these treatments punch little holes in the vaginal lining, and the idea was that would irritate the tissue and it would regrow new blood vessels and more collagen, and that would make the vagina stretchy and produce lubrication in a way it wasn't. Well, any treatment for women's sexual problems have a huge placebo or sugar pill effect. So if you give women any credible treatment, a big minority of them will say, I feel better, my sex life has improved. So how do you prove that these treatments really work? Well, they did what they call sham versus real laser trials. They put in a device in the office that looked like the real laser, but it didn't have the real laser effect. And then they followed women with questionnaires and said, how's your sex life doing at 3 months, afterwards, et cetera. And what they found is basically the sham treatment was just as good as the real laser. And there are even fewer studies of some of these newer heat treatments, and some clinics are selling these heat wands that you can use at home. And maybe they work, but I wouldn't waste my money on them personally. And also, they've now done some trials where they randomize women to either get a laser treatment, to use vaginal estrogen, or to use the vaginal hyaluronic acid-based moisturizers. And basically, all 3 treatments worked equally well. So to me, if you can get the same effect from a vaginal moisturizer, why are you going to go with a laser treatment? Stretching out the vagina may prevent tightening and tight bands of scar tissue that sometimes form after menopause and cancer treatment. And we think prevention works better than waiting until the scarring occurs, because then it's difficult to stretch out and painful. So one way would be to have partner sex, if your partner has a penis, involving vaginal penetration or a sex toy otherwise. Another way is to use things like these little vaginal dilators, which you can buy without a prescription on the internet. And you can start with a very small dilator that's about the size of your finger and slather lots of lubricant on it, and I'll explain what you do next. And just mention, too, that there's another kind of dilator. There's one called the Millie that is an inflatable dilator, so you can start small and inflate it, and it has a vibration setting which might make it feel better for some women. So you start with a small dilator, you practice learning how to tense and relax the muscles at your vaginal entrance, which are the same muscles that you tense and relax when you stop the flow of urine. So if you haven't identified those muscles, that's one way to do it. And once you know where the muscles are and can isolate them, and that's something that a pelvic floor physical therapist can also help with lots of fancy biofeedback equipment. You start with a small, very well lubricated dilator, and the first goal is just to be able to slip it into your vagina without it hurting. And then to hold it there for a few minutes, be able to wiggle it around and have none of those things hurt. And when you can do that, you can move up to the next larger size until you gradually move up to a dilator that's close to the size of an erect penis, if that's your goal, is to have penis and vagina intercourse. Another way to get closer from just using a dilator alone to having sex with a partner is to have your partner put the dilators in under your guidance, starting with the small one, and with you telling your partner, when you're relaxed and ready and when to slip the dilator in. And that gives you less control, so it takes a little more effort to stay relaxed and avoid pain. Other specific techniques, a lot of women, as I mentioned, have pain with deep thrusting deep in the vagina because of scar tissue or the bladder being down lower in the pelvis. And this O-nut device at the bottom is a series of 4 silicone squishy rings, and you can use just 1 or up to 4, and you can put them around the base of your partner's penis if you're in a heterosexual relationship. And then when your partner thrusts into your vagina, your partner gets friction and pleasure from the O-nut, but his penis can't go deeply enough into your vagina, hopefully, to trigger your pain. Another thing that helps is to use positions for intercourse that minimize deep penetration and give you control, like being the partner on top or lying side by side. And again, learning how to relax those muscles at the vaginal entrance. Low desire is probably the most difficult problem to treat because it has so many factors. Like, women often think, oh, well, it's just menopause hormones, or my testosterone is low. But look at all these things that go on when you're going through cancer treatment that can affect your desire. Sex may be painful, you're stressed out, you may be depressed, you may have chronic fatigue or nausea or diarrhea. Unfortunately, going through an illness can highlight a lot of relationship issues if there's not good communication or you don't feel supported by your partner. You may feel bad about how you look, so body image issues. You may feel like you're no longer feel sexual, or your body feels like it's been medicalized by your cancer treatment. And we all know that women in cancer, and I heard someone mention it in the last session in a question, often get on many medications, including antidepressants and anti-anxiety drugs, which both damp down your sexual desire typically, and opioid pain medication, which is an absolute enemy of sexual desire. So can you get better desire through chemistry? That would be nice. And the FDA did approve 2 drugs in the last few years for women's sexual desire. One is a pill called flibanserin, or ADDY, A-D-D-Y-I, that you have to take daily. And another is an injection of a hormone bremelanotide, which is called Vyleesi. They managed to get these drugs approved by whining a lot. I'm sorry, but the drug manufacturers went to the FDA and said, there are all these drugs for men's sex lives and we have nothing for women, and you darn well better approve these drugs. But you look at the clinical trials and these drugs are basically barely better than a sugar pill. So they managed to get them approved, but they don't work all that well, and they have a lot of side effects like nausea and headaches, and they're disappointing. Also, there's no testosterone dose or way of administering that's approved for women, and again, why? Because the clinical trials didn't show anything. But a lot of women take testosterone, and maybe about half of women say they do get some boost in desire from it. But also testosterone gets converted to estrogen in the body, and nobody knows if that's a lot safer. We think it's safer than taking estrogen, but So unfortunately, there's no magic answer. So what can you do to increase desire? Think about what sparked your desire before your cancer. Maybe it was playing tennis or dancing or having intimate talks or cuddling or romantic evenings with your partner or reading or listening to erotic stories or self-touch. Improving sexual communication and pleasure is important. Treating pain and minimizing relationship conflict and depression, and working with your doctor on changing any medications that might be interfering with your desire. When you go through cancer, it often gets you into a caregiver relationship with your partner rather than feeling like a lover, and then it's hard to switch back. And that can be a challenge. And also, many partners don't initiate sex because they're afraid that they're burdening you or that they're going to hurt you physically. But women interpret that as, oh, he doesn't find me sexy anymore. And if you don't talk about it, that can become a real issue. So avoid our culture's performance model of sex, like everybody has to have orgasms and sex always needs to end in penetration, or let's wait till we can go on a vacation. Make yourself a mini vacation. Just take time on when you can have privacy and relax for a couple of hours. Remember how much fun it was when you were a teenager, hopefully it was fun, and you had petting with your boyfriend or women friend, and try sex in the shower or tub, get in the mood with dancing, and practice all by yourself. So the goal is fun, not perfection, and trying sex without intercourse to take away the pressure for the man to have erections and for the woman to reach an orgasm. Choosing times when you're not in pain or exhausted, so you can't be as spontaneous, perhaps, as you used to be. And either partner can initiate sex. And I'm going to go fast here. In the handout, you'll see I describe some couple touching exercises and ways to enhance sexual communication, like talking outside the bedroom and figuring out in advance one or two small positive things to ask for instead of making everything into a catastrophe. And also, dating after cancer is a big concern. And a lot of women don't date because they don't want to face getting rejected. But being rejected is a normal part of dating at any time. And hopefully you wouldn't want a relationship with someone who thinks you're not lovable because you've had cancer. For younger women, talking about and disclosing fertility issues in a new relationship is scary and needs to be discussed. And sometimes online dating is a way of flirting a little and putting your toes in the water. There are even specialized sites for cancer survivors, people over 50. But of course, be safe, never send money, no Nigerian princes, meet in a public place at first, and consider even an online background check. So I'd like to stop there because I know you want time to ask questions. And also we have the drawing. So is anyone brave enough to ask a question? Yeah.
What's the name of that site for cancer dating?
Google it because I don't remember exactly. I think there are two of them, and I'm not sure how active they are, so I'd take a good look at it and see is it 5 years old or are there still a lot of people using it? Well, you may be one of the lucky ones, because as I mentioned, it's just a quarter of women who stop having sex. But it's possible that over a few months, things may get a little bit worse, and probably some of the best things you can do is go ahead and be proactive in using lubrication and staying sexually active and see how that works for you. I wish I could give you a more definitive answer, but, we don't really have a good timeline on that. But I think it usually happens fairly quickly within the first maybe 3 months, certainly, of taking AI. There's no too late, but once the vaginas become very narrow and what the medical term is atrophied, and if there is, like, some women actually get a band of tight scar tissue at some place in their vagina, which constricts it, but that's more common after pelvic radiation, which isn't such a common treatment for LGSOC. But then it's not too late. It's just that you may need more help and guidance, like from a pelvic PT, and it may take more patience and trying different things to see what works. Around the country, there are a whole group of physical therapists who get special training in pelvic floor problems. I know MD Anderson, at least a couple of years ago, had one on staff. And also you can look on the internet for pelvic rehabilitation certified physical therapists, and there are directories. So some of them have private practices, or your oncologist may know of one. And they are kind of the specialists in helping you try to work with some of those vaginal problems and loosen up the muscles and try to stretch out the vagina. It's certainly more effective at that dose than the real ultra low dose ones are, and I know a lot of women who get the real low dose version alternate it with the moisturizer because one alone doesn't do it.
Yeah.
There's just no research, and when they try to do the research, no women want to participate,
Yeah.
and so we don't really have a good basis. And also, I've seen a lot of women whose oncologist says, "Don't touch it," and the gynecologist says, "But vaginal estrogen is totally safe."
Yeah.
So it's very confusing, and it's unfortunate.